G'day, my name's Ben. Welcome back to Primary Survey. We're about to dive into a OSCE sim. We just uploaded the nausea, or I just uploaded the nausea vomiting sim, and I was going to do the chest pain, but I thought it might be better to do something a bit freestyle. So, having a quick look, preferences, partner's name is Brian, standard follow instructions. He's still going to throw things in. QAS jurisdiction, West Moreton is my haunt. Difficulty 1 to 8. Keeps it quite interesting, and we've got everything ticked, so we'll just see what we get. So simulator OSCE start. 1C, anaphylaxis severe allergic reaction. Fernvale, 20 minutes to hospital in Ipswich. Not too bad. I'll acknowledge that one and see what we get for our windscreen survey. Suburban residential property, driveway clear, single story brick dwelling. Not too uncommon for Fernvale. No external hazards. Humidity is high. Area is still. Access via front door is wide open. Single patient in the lounge room. Oh, morbidly obese adult. Great. Visibly distressed. Single patient. Oh, yeah, I suppose female bystander, whatever. Look, we'll get in there. G'day. And this is Brian. What's happened? Asking, I'm feeling for the patient's radial pulse. And I'm on that respirate. Cool. So I like to put everything in quotation marks when I'm talking. Yeah, right. And obviously then you're describing your actions as well, so it's a little bit separate. So yeah, I've got weak radial, rapid and thready, skin warm, diaphoretic, significant tachypnea, accessory muscle use, stridor, able to speak. Cool, we need to get some anaphylaxis on board. Well, came through as anaphylaxis, so let's get... Brian, hooking you up to our monitoring gear. Is this? You're having allergic reaction. We won't ask about that. Alright, so what we've done, assessments, we've done our vital signs survey, so that pops it in here. I've pretty much done a RESP assessment anyway, and we're just going to try and confirm that it's anaphylaxis. Not as vigorously. Into your leg. I'm going to pop a little in there in case we need to get some more medications. Actually, we should probably get some oxygen on him first. Whatever. So we're going to get some adrenaline on board. We're going to get 500 mics of adrenaline. Pop. And oxygen mask on you. And then... Alright. So, we confirmed it's anaphylaxis. We've got swelling. We've got stridor. We've got everything going on. So we're going to go straight for our adrenaline. So obviously drug admin, adrenaline, pops it down here. So we're going to click on that. We're going to go, I am, quick drug check, 1 in 1, adrenaline, 6/20/27. We're indicated for anaphylaxis. We're not contraindicated that. No, contras for adrenaline. We've drug checked it, so confirm that sucker. We're going to go 500 micrograms for adrenaline. And I'm going to do it. Administer that one. So again, that's going to go in there. Drug admin. So oxygen is a drug. It is hiding. It is oxygen. So we're going to get him straight on from non-rebreather because he's sat at 85%. His blood pressure's low as and his tachy as too. So let's just get him on a non-rebreather. Indicated because he's desaturated, not contrad. 15 litres per minute. Excuse me. Brian's going to pop that on. We'll administer that. What else did we want to do? We wanted to try and get IV access. I don't think it's too much to put in this one. We indicated because we're going to be giving hard record. We're going to be giving... I'm going to probably give a lot. We're not contraindicated. We're going to try... It's pretty flat, but let's try an 18 in his cube. Brian will do that after he puts the oxygen on. And that's a lot to do in one turn. So we'll get all that done. So we get adrenaline in. Got that O2 at 15 litres. Brian places a non-rebreather mask. Patient struggles with the interface due to facial swelling. Ooh. Adrenaline is in lateral thigh. Manages an 18 first attempt. Notice tough stick due to tissue edema. That's fine. Tongue appears more swollen from the larger portion of the artery. Oral cavity. We've still got inspiratory stridor, high pitched and loud. Urticarias now. All right. He's still, even on the 15 litres, he's going to shit. So what we're going to do, we're going to get a CCP. We're also in Fernbar, so we might even consider a helo. I don't have a page. So, male patient. So, when we do a... we need to do basically a clinical sit rep, yeah. GCS 15, significant respiratory distress. Words saying 78%. 115 litres per minute. Hypertensive at 60 on 30. That's not great. Tachy. Respirate 36. Oil strider. First adrenal just gone in. What else can we put? That's pretty good. So let's get a CCP on the way. I'm really contemplating whether we ask for a helicopter because he's going to be hard. We're going to get a bag of fluid up. Brian, let's get some fluid. IV indicated because he's hypertensive or buggery. Flow rate mils, I don't know. Let's just put 10. I mean, we use the drip feed, the gravity drip feed, so I don't really know what it works out to, but let's get a bag of fluid up. Oh, that's why I've been doing some wrong things. 20 mils? Oh. Okay. He's wildly hypertensive. Let's get 5 minutes. I might put that into this action. Oh, excuse me. It's late and I'm just trying to smash this out because I love doing them, but also yeah. I should be asking family. I'm gonna go straight for the next adrenaline. Old mate is a bit unwell. Adrenaline 1 in 1, 627. Mics. Alright. Cool. So we're requesting a CCP. We're getting a fluid bolus up. 12 minutes out. Oh, 20. That's the size of the bolus. We got a 500 ml bolus. Silly bugger. Shaking his head. That's good. Subcostal insert. Recession worsening. Appearing lethargic. Okay. Yeah. So that's me misunderstanding it. So that's actually a 500 ml bag, not 1,000 ml. But that's fine. 20 ml forward. Bolus completed. Cool. All right. That's the second. God, his blood pressure's just gone to unrecordable. He's sitting on 65%. Let's get him. Alright, so it's got 5 milligrams on. We're not going to get an airway adjunct in a swollen airway. It starts to get tricky here because obviously we aren't really indicated for an eye gel yet, but if his airway swollen, then we've got risk of laryngospasm and a lot of problems around getting access to the airway with the swelling. We might consult because we're refractory to our 2 anaphylaxis. To our 2 adrenaline. All right, so we're going to start thinking about obviously severe anaphylaxis. We've also potentially will be beta blocked. Could be why it's not working. So I might look at glucagon as well. Patient. Okay. All right, so we're going to get not skills. There's nothing we can do in there at the moment. We're going to get a third adrenaline on board. So I am 1 in 1. 0627 indicated for anaphylaxis, not contraindicated. We'll do it at the 5 minute mark. 500 mics again. I'm going to get Brian to put that on. I'm going to give glucagon. I think we're supposed to consult first, but I'm really concerned here. He's not in a good way. We are indicated for anaphylaxis refractory to IM adrenaline. We're not contraindicated. I think glucagon is either just allergy or nothing. Drug checked at 627 glucagon. And I'll get Brian to give that after the adrenaline. Oh, fuck, it's 1 gram, I think. Oh, I'm going to have to check. Hang on, stand by. QAS DTP, glucagon. little bit embarrassing. Glucagon, gluca. I know it's 1 vial. Here we go. Yep, 1 milligram IM, single dose. Refractory anaphylaxis, pitches in the hypertension. Refractory to 3 IM adrenaline and fluid challenges while we're running fluid. So, I can't see it. Anyway. What did I just say, 1 milligram? Yeah. 1 milligram. That sucker's ready to go. We're going to consult. Doesn't really matter which one consult. So, we're doing a S-bar. So, situation. Hello, Ben Lang. ACP2 at Lowood. Also, with male patient. Male patient to anaphylaxis. 2 peanuts. Currently unrecordable blood pressure. We need to get him supine the phase race as well. Unresponsive 2 times IM adrenaline. Background. Anaphylaxis. Remains that. 60 BPM. Unrecordable BP. 65% on 15 NRA. 36. Very high. Looking for advice, giving 3rd IM adrenaline. Now, here we go. So we're going to queue that. So we'll send that and we'll get a bit of advice. We should have said CCP something as well. Okay. Okay, cool. We'll move to supine. 3rd adrenaline. And IM glucagon is in. Now he's got difficulty managing secretions. 58. Takes a lot of tablets. One is metropolol for his heart. Okay, he's got one of those puffs for his chest. Chub. Situation is clear. Given refractory hypertension, history of metropolol, authorization for glucagon. Cool, I've done that anyway. Continue after current. Prepare for adrenaline infusion upon CCP arrival. You have air junks and suction. Air junks, far out. Air junks, that's actually a really cool way of shortening that. Airway adjuncts and suction ready. Well, yes, we kind of do. I did say that. We need that ready. GCS 10, responding to painful stimuli. Okay. Cool, let's get that eye gel in. Snoring. Okay. Hey, thanks. Situation should be glucagon is in. Continue. For now. Need to open his airway because he's snoring. We need. Let's try for gel. If he's dropping his GP. Supine with legs up. Let's get some get some suction going to help with the respirations. Alright, so skills. We are going to opening maneuver indicated. We're going to do a triple. We're going to let Brian manage your airway. We're also going to need to do some suction. Or pharyngeal suction. I think we should be fine with a yanker. Brian can manage that once he's opened the airway. What am I doing? What have I said here? Where's the CCP? I'll just go another adrenaline. I am adrenaline. Indicated, not confirmed. Drug checked. Bang. 500 mics. In at 5 minutes. We've got glucagon on board. Looking at ABCs. Airway. Airway is going to be intact in a moment because we're opening it up. Breathing is tachyapneic. We can't do much about at the moment. We're probably going to end up having to bag him. C, circulation. Look, his blood pressure is trash. We've got adrenaline going in to try and manage that. We need an adrenaline infusion. That'd be great. And we've got the fluid bolus running. We're doing everything we can. ABCs. Being managed with maneuver. And I ready to go. Maneuver suction. Breathing. Circulation. Boom. So this is pretty intense. Hey, look, we've got a recordable blood pressure pack. Oh, we've got widening QRSs. Okay. Triple airway. Air pain seems slightly improved. Tongue malaise. Suctioning clears frothy secretions and saliva. Fourth dose is IM adrenaline. GCS 8. So he's cooked. Chest wall expansion is poor due to morbid obesity and COPD. Airway. He hasn't dropped his GCS enough to get an IJO in yet because he's still responsive. He's gonna have he's gonna gag. I mean, we could put an OPA in, but again, it's really not going to help because our swelling's sort of more further back than an OPA is going to be able to assist with. We're just going to be managing it. Here's our CCP here yet. Until then, more airway management. Suction and maneuver. We're going to need another crew. Fuck, we're in Fernvale. We're going to need another crew for extrication. Might get fireys. Triple adrenaline. 5 minute mark. So I'm not going to add those skills in there again. I've quite obviously said that they're still getting done. I am adrenaline indicated, not drug checked. Fuck, it's expired. 123 discard. So when they are expired, sorry, I'll just replay that. It's not going to give it to you yet. You just discard button and then you can click the little cross up the top and we'll grab another one. Fuck, that's expired as well. Discard. Try again. Someone didn't check their kit this morning. That's better. 06 2027. 500 mics, adrenaline. Disposition, we're going to want additional crew. For extrication and fire rescue for extrication. Extra fireys. Alright, CCP has got to be here. Sometimes you have to remind it. CCP 2 minutes out. Fire, yeah, Brussels sprout. Silent chest on exploitation. Fudgy widening QRS. Alright, his GCS 3, let's get that in. Let's get that agile in. If we can. Start bagging. Alright, 12 per minute. High flow. We really need an adrenaline infusion. Yeah, let's put adrenaline in. This is free. Swelling. No effect. Probably. That's fine. We'll just skills. I mean, they're going to want to tube him, but gotta be a size 5 agile. Oh, look. Listen up. CCP has arrived on scene. Yeah, didn't think we'd get that in. Shark fin obstructed pattern. CCP Sarah, g'day Ben. I hope that's it right. He's peri-arrest one mother. My gel isn't going to cut it. We need to move to an adrenaline infusion. Yes, thank you. You're not going to get it. Okay. And let's get the second one in. Okay, what am I doing? I'm doing another IV. Should have done this earlier. Should have thought ahead. We'll try. We're going to do a 20 because I don't think we're going to get it. Look, he's a beast, so let's try a dorsum. Whoops, I need to actually send that. So I'll do that. Drug admin. Adrenaline, 500 milligrams. And then we're going to have to draw up the IV adrenaline. I am indicated, not contra. Should have got another crew earlier. A lot of work to be done here. Skills, BVM, ventilation. So you don't actually need to do this. You don't need to do the... you don't actually need to add these in because we're talking about them. go. 6 doses of adrenaline. BVM going. IV access didn't work. Okay, forget the hand. He's 2 shot down. Going for IO. Beautiful. Use ETCO2. Climbing and 6 up 50 again for 10 minutes. Ready. I can't see anything. Rapid inserts. Wide complex tacky into a profound brady. Okay, so he's arrest. Okay, alright, we need to get pads on. We should have done this before. Alright, so it's going into an agonal rhythm. I'm not sure where I'm going here. Try getting adrenaline. I don't actually know if I can do an infusion on here. Okay. I'm not sure what dose she wants. Oh, look, Fire's arrived. Let's just scrap that. We'll ask her for this. Yay! He can get the additional group to also arrive. He's gonna forget drawing it up. Backing the one of, I didn't know we had that. Brian, pulse check. If there's no central pulse, went to CPR. Well, actually, systole, manual chest compressions, something for the adipose tissue. The man in tube, he's too swollen, going straight for the neck, said you crack on, get the pads on. Take off the BVM while I cut. I need to ventilate through the neck soon, he's gone. So initiates lateral incision out of the crack. Congestion. Lovely. Okay. Iris can do the I can't spell them. Is sorting way out. Oh baby. Like at this point, it's really Sarah's running the show. I am, in my head a little bit. All right, fire or rescue. We're doing chest compressions, high quality, excellent. Sarah is tubing. Brian is ventilating at the neck. Additional airway is secured. Fantastic. Okay. everyone's just kind of in their roles now. ECG. Our ECG is kind of stopped up there. Anyway, managed breathing, and circulation. Let's see here. Words, anaphylaxis. Okay. I don't know. So I've got our ABCs intact. Reversible cause we already know. Surgical airway is patent. ETCO2 is 29 with compressions. Cool. Well, we're running the adrenaline infusion. Another bag of fluid. Okay. Hypoxia is being managed by the crick. Reversible is rating toxin system. Tension. COPD in order. Slow ventilation's been checking within the next 2-minute mark. 2 minutes. Where are we at? I'm kind of like everything's being managed without me now. Hands off clear for a real joke. What do we have? I don't fucking know what we've got. We've got a narrow complex rhythm with a weak rapid pulse. So that's good. So we've got ROSC. We've got fluid running. We've got ventilations running. Got COPD. We really got a really tricky one here. I think we just need a 12 lead. Oh, gosh. Okay. What's my 12 lead? I want to get him in the car where he has ROSC. We've got peripheral bed is still wide open. Third. Fuck me. Okay, so we're really adrenaline run here. Jesus, pressure infuser on the second bag. BP is creeping up slowly. Fantastic. He's gonna get more glucagon. Okay. Lucky we got all these extra crews, hey? Okay, let's go. Glucagon on board. And ready to move. Okay. Try and look at the first. Good lord. Surgical airway stable. Facial edema, somewhat stable for now. Okay, that's a load for you. Alright, there's nothing that I can really add to this. The CCP is has run the entire show here. So look, we've got a synchronized lift, we've got a GCS3 patient, no spontaneous respiratory effort, ventilations via a surgical airway. We've got 2 infusions of, we've got 2 infusions of adrenaline going. We've got ongoing hypertension. It's very, very sketchy. Yeah, I'm just gonna go like this. I don't know why Brian's driving. I'm driving. Transport to hospital. Transport disposition, code 1. We're not going to PA. I don't know why she says that. GCS3 post-ROSC Anaphylaxis 2 infusions remaining. Okay. Let's just go. Let's see what this gives me. I'm really interested to see how I've done there. 82 out of 100. That was a long case. We're at 42 minutes. Yes, it is a high intensity one. Okay. Excellent adherence to the anaphylaxis DTP, distributive shock, adrenaline every 5 minutes, recognition of the beta blocker, yeah, fucked, man. Q, escalation of care, we really needed that CCP earlier. I don't really know if we could have shortcut that. Like, I think he was going to go downhill anyway. Like, I guess if we got the adrenaline infusion going earlier and maybe got more glucagon on board, that was sketchy. I mean, we did everything we could, and then the CCP kind of took over. Cool, closely. Yeah, we didn't really, transition wasn't smooth. We should have had those pads on really early. And been doing rhythm checks. I kind of left it up to the CCP to do that. So, initial assessment, airway management. Cool. Post-ROSC cares. Well, we're slightly late in. Yeah, look, the 12 leads being really sketchy on here, so I didn't want to actually have to do it. That's why we went with a freestyle case instead of that. So, yeah, look, fluid volume, I didn't mean to do 20. I thought I was asking for a rate. My bad. Excellent. Anaphylaxis fluid requirement, revisit hypertension. So, cool. What was the going turning point? Actually, what did I do well? Managed according to forward. I'm ready to transition. Submit reflection. See if that works. We'll try posting that. Submit reflection. We'll see what the insightful reflection, particularly regarding the clinical turning point, rapid deterioration of refractory cases, focus on proactive measures such as early pad application, aggressive fluid resuscitation, great peripheral awareness, high acuity risks, To deepen this, consider what physiological clues or red flags. Yeah, we should have got his medication early. This is why it's sampled allergies and medications, but he went down real quick. Anyway, yeah, if we knew that he was beta block, we probably would have consulted for glucagon really early and got a CCP much earlier as well. Showcase isn't working, that's fine. All right, guys, I'm going to leave it there because it's now 10 to 2 in the morning here. I didn't intend to run a long case. I was expecting for like a cruisy 10, 20 minutes, something or other. But look, that was really good. I'm really glad we got to do it. And thanks for your time. Thanks for watching and keep in touch.